Support for this podcast comes from iTube.net. iTube is ophthalmology's leading source for high quality ophthalmic surgical videos, educational series, spotlights, and more. Visit iTube.net or follow us on Instagram at iTubeNet.
This is Ike Ahmed,
And I'm Arsham Shaybani.
and we want to welcome you to GT the Podcast
We're bringing this to you together with BMC and Glaucoma Today,
to offer audible insights into current topics in glaucoma care.
presented by the authors of our latest, most read GT articles.
Check it out.
Welcome to another episode of Survey Says with Dr. Paul Singh. On this special edition of GT the Podcast, Dr. Singh presents a real patient case from his practice and asks his guests to share how they would approach it. For this episode, Dr. Singh met with Drs. Emily Shaline and George Tanaka to get their thoughts on today's case. The case involves a 68-year-old white woman with moderate primary open-angle glaucoma and a history of SLT and cataract surgery with combined canaloplasty and 2 iStent inject implants. The patient is on 3 classes of topical medication, but is very unhappy with drops. Her IOP has remained at target in the middle teens, and she has not shown progression on OCT or visual field testing. Together, the group discusses the possible next steps, including drug delivery, repeat SLT, surgical intervention, or continuing as is. They talk about the patient's current circumstance and the value of making a choice that will improve her quality of life. They also considered the merits of different surgical options in this case, including the potential benefits of a supraciliary spacer. Later, the guests find out what Dr. Singh did, and they compare their opinions with the results of a social media poll of GT's audience. Tune in to Survey Says with Dr. Paul Singh.
Well, hello, everybody. Welcome to another episode of Survey Says. Thank you for joining us. My name is Paul Singh, glaucoma anterior segment surgeon out in southeastern Wisconsin, and I'm really pumped because it's going to be a one-on-one session today. I'm really pumped because we have Emily Shaline out from Michigan chilling out with me to talk about this cool case that we have. What's up, Emily?
What is up? I wouldn't have talked over anybody else, but I'm excited. I get the floor to myself.
It's all you, man. It's just you and me. This would be
Wow.
awesome. But that's kind of fun, though. I love having multiple guests, but it's kind of cool to have just one person be like, let's just talk,
Yeah.
For me, it's funny because I'm in private practice like you are as well. And, sometimes I just don't have the opportunity to kind of just talk with other glaucoma peeps. And so it's nice to just have this. It's almost like therapy.
Yeah, it is nice, but I do feel like in the last 2 years as a glaucoma community, we've really come together in terms of our communication. Whether it's groups online where we're chatting, listservs, forums, via text, group chats. I feel like as a community, we've really been communicating a lot better with each other. And it's great because now I have so many more people to draw on when I have tough cases.
That's awesome. And you're absolutely right. Actually, when I kind of came out of fellowship 20, many years ago, it wasn't like that. And of course, technology's helped too, but I think just the vibe. I think the vibe of everyone supporting each other and kind of helping learn from each other. And I think it's actually a huge difference. So that's true. So thank you for that. And you're part of that too, by the way. But I know you're also a podcast person. Talk to me about, you're also part of the AAO podcast too, right?
Yes, absolutely. So I am the host of the AAO Journal podcast. And so all of the American Academy of Ophthalmology journal family, if you submit a paper to that family of journals and we find it particularly interesting, or it is particularly interesting or groundbreaking, we love having guests on our podcast to talk through their paper and kind of interesting facts behind the paper, why it's important in this sort of date and time. And it's been a wonderful experience. It's been great for me to really be able to have one-on-one conversations with some amazing people in our field, and definitely keeps me up to date.
That's awesome. And how do we find it? Where do we go to get to check out some of the episodes?
Absolutely. You can find it on the American Academy of Ophthalmology website and also on Spotify, on Apple Podcasts, and give it a listen. We would love to have you.
I'm going to do it. Awesome.
And
Well,
submit your papers so that we can have
that's
you
cool.
on.
Yeah, we got to get more papers out there so we can talk more and we can
Yes,
hear you talk more.
exactly.
Absolutely. Well, thank you for that, and welcome to the show here and the program, so to speak. I love it. I feel like a talk show host there. But no, it's really cool to have you here. So we're going to talk about the case. So as you guys all know out there, Survey Says is basically a survey where we survey the audience in the social media world, LinkedIn, Instagram, etc. And we survey a case that's a real case that I did and I had in my clinic. And we just ask what you guys do and what would you do? What would you do? And then we have a guest to see what you would do. And then we just kind of compare and just talk about kind of what this world would do. So I'm going to talk about the case, describe it for everybody again, and then have you kind of mention what you would do as well. So we have a 68-year-old woman with moderate POAG with a history of SLT twice and cataract surgery with combined canaloplasty and then an eye stent as well. So had 2 eye stents with canaloplasty, history of SLT prior to that. She was on 3 classes of topical glaucoma drops, PGA, Brimonidine, and Timolol. Pressures at target in the middle teens, but then patient was miserable with those drops. So did well for a while with the stent and with canaloplasty, back on drops. Pressures aren't high, but she's tortured with the drops. She's had no real significant progression on Fields or OCT as well. Her CCTs are normal. Hysteresis is slightly lower on 9.2. So again, not a progression patient, but a patient whose pressures are kind of at the middle teens where it should be, but yet on 3 drops. History of MIGS and cataract surgery. So what are your thoughts on that? Like, by the way, is that something you do a lot? Did you combine before we had the whole MIGS issues there with, the MAX? But have you combined like canal dilating and stenting before, or goniotomies and
Those were the days. Those were the days. Those days seem to be gone for right now. Absolutely. I'm so sad. You know, our patients really were benefiting during that time. And I will say that this is a great case. And this is also, these are my ladies, this patient population. So this is a case that I see all the time. But yeah, I think I often combined minimally invasive glaucoma surgeries like canaloplasty and goniotomy before we weren't able to do that anymore in terms of the changes in the max. But this is a patient that I see every single day in my clinic. It is, and what's interesting about this case is your answer or everyone's answer would be completely different even 5 years ago than it would be today, which really shows how much our field has grown and how many more options that we have. But I kind of start out thinking about this patient. First of all, Paul, do you think there's a wrong answer here?
No, I'm gonna let you
You don't
talk.
think there's a wrong answer?
No,
Okay, well, I think there's a wrong answer. So the wrong answer is that we do nothing.
nothing. There
Yeah.
you go. I kind of knew it, but I was like, let me let her say it.
Yeah, yeah. So that's a huge disservice to our patient. And um, when I see a patient like this, the first thing I think of, okay, what would I want if this were my eye? And you've discussed this so many times, and it's been an earworm of discussing with patients this idea of a surgical toolbox, right? So we have multiple options over your lifetime to help preserve your vision. And in this case, we are talking about vision preservation, right? Because this patient's ocular surface disease, forgetfulness, sort of intolerance to drops, this is affecting her vision and this is affecting her quality of life. So there is a wrong answer. We do need to do something. Um, I think that in my mind, the choice is between a repeat angle procedure, a suprachoroidal procedure, and an incisional procedure. And I think that there's a couple of things we have to think about here. So first of all, this is bilateral disease, right? It's not just like one eye that we have to intervene on, it's both eyes. I don't think repeat SLT is the answer here. I don't think that's going to get us off of 3 drops, right? She's on 3 classes.
3 classes, yeah. And by the way, so I didn't tell you this history. I'm not sure this would change your opinions in general, but her history when she had SLT in the past didn't have much response with previous SLT historically. So not sure if that would affect kind of your thought of her not having the outcome we want with conventional MIGS in general.
You know, it's sort of hard to tell. So I think that if we did something like a repeat angle procedure, so say, for example, repeating canaloplasty, doing a goniotomy, maybe it still could reduce her drop burden significantly. Is it going to get her off all her drops? Probably not. Would it be okay if she was on one preservative-free prostaglandin analog? Maybe. I think also a good choice could be to do, if you're able to in your MAC, do a goniotomy, canaloplasty, and then put a beautiful iDose right in between those eye stents. And then, maybe she will get off all her drops. But I think that in this case, I really try to take a step-by-step approach and kind of talk to the patient about what are the options and what I think is the best option.
All right. Well, we have an intruder, but that's okay because it's our good friend George Tanaka who joined us. What's up, George?
Hey, what's up? Coming in from the West Coast here to join you folks. Great to be here.
Yeah, it's great to have you here from the Bay Area, man. So we were just finishing up with Emily's perspective on this case, real quick. Again, to 60-year-old woman who's got history of POAG, SLT a couple times in the past, cataract with canaloplasty and the eye stent injects. Pressure did pretty well for a while, but then now back on drops. Unfortunately, on 3 meds, miserable with 3 medications. But she's not progressing on Fields or OCT. So the question is, what do we do? Do we leave her alone, or do we do something? And Emily was very clear that we've got to do something because you can't leave this patient suffering for the rest of her life, even if the pressures, quote unquote, are at target. So Emily's like, let's go back in the conventional pathway potentially, but also you're just mentioning not just the conventional pathway, maybe a Zen you were saying is an option too as well.
Yes, absolutely. So I think, if we went back in the angle for this patient and did another canaloplasty and goniotomy, and maybe put a beautiful iDose right smack in the middle of those eye stents, maybe she'd get off some of her medications, but it's not a slam dunk, right? Because I think you were saying before she didn't do very well with SLT. So maybe the angle is dead at this point. But I think it's still a very reasonable option to pose to her. And I think she would also do beautifully with the Zen, but she is young. So if she were 75, I'd say let's do a Zen right away. She'd get off all of her drops most likely, and this would carry her for the remainder of her life. But this patient's younger, she's probably active. She's probably picking up grandkids. She may not have time for bilateral incisional surgery, and also it may not carry her for the rest of her life. I also think that a suprachoroidal surgery, like something like Alaflow, would not be a bad idea here. But I also think that we're still learning about the predictability and durability of those suprachoroidal options. And so, kind of where I'm utilizing them in my practice right now is for patients who are facing sort of a second incisional surgery. But I don't think it would be a bad idea by any means. I think where I kind of come down is the quickest recovery for her and would be the going back into the angle. And she may very well do quite well with that and get off at least two, if not all of her drops potentially.
Real quick before George chimes in, Emily, you made a really good point. I really want to stress this out, or not stress out, but stress this rather,
You're
and
already
point it
stressed
out
out
that
about stuff.
yeah, I'm always stressed out. It doesn't matter anyway for me. But no, but I think this idea of yeah, you don't have to get them off of all meds to have a value, right? They're even as getting off a single agent or combo agent, let's say, is it not only an improvement in cost, less preservatives, less chemicals in the eye, less forgetfulness? I mean, so there's still a value to your point, Emily. So even if you did a conventional MIGS and did something in the conventional pathway, and you got them off for one or two with the iDose, et cetera, and canaloplasty goniotomy, yeah, absolutely right. You still have options of Alaflow later on, or subcon Zens, or anything else later on, ECP, we name it. So I think that's a really good point. Absolutely. But George, what are your thoughts on that? This kind of case so far. What do you think?
I think Emily just hit it right on the head. I mean, she's failed some angle MIGs already. She's miserable. The whole interventional mindset is to improve quality of life, not just worry about this number that we call the IOP. And so if you go back in the angle with some other angle procedure, totally agree. The angle might be, the collector system might be atrophied. You don't know what you're going to get. And I think a suprachoroidal option, now that we have Alaflow, is a wonderful, way to go. I pretty much use it also as Emily does, and trying to avoid, another incisional surgery. I mean, I'm a huge fan of Zen, but I agree with Emily. She's kind of young, even though she's Caucasian. It's not a slam dunk. And I think she has at least as good a chance for some success with an Alaflow as with a Zen. And I've actually done a lot more Alaflow recently than I have with Zen, for that very reason. You have these younger patients, right? You don't want to do a trab or two on them. And they've all had their MIGs and they've worked for a while and now they're failing. And now what do you do? Do you go subconj or do you go suprachoroidal? And I do think, suprachoroidal, the Alaflow is a MIGS. It is a suprachoroidal MIGS. It's our successor to the CyPass, which was a great surgery in the right patients. And it's fantastic that we have it at our disposal. I do think it's a little bit more flexible than the CyPass. We can kind of alter the way we make our clefts. We can put in different, numbers of spacers. I do agree also with Emily that we don't completely understand why they fail in some patients, even though it looks great. The pressures spike up. I have some thoughts about that, but I would definitely offer this patient an Alaflow before we go to a Zen or a Traver 2. And of course, we preface that by saying, hey, we'll get you definitely off some drops. You may have to use the drops for a while, but your post-operative recovery is really going to be excellent. I mean, I had these people back doing their normal activities, going to the gym, picking up the kids like at a week or so, just like a Zen, actually. These chambers look great. Yeah, there's a little bit of blood, maybe a few days that clears up, just like our, angle MIGs. So I think Alaflow is the way to go with this patient. Totally agree with Emily.
Yeah, no, these are really good points, you guys. And a couple of things that you said that I think were important. First of all, it is a MIGS, and it is part of our natural outflow pathway. Yes, it's a secondary outflow pathway, not the conventional, pathway, but it is part of the natural pathway. So I tell my patients, there's another way we can access your drainage system internally, which is your natural drain through this mechanism. So you're right. It is something that when we describe it to patients, it's still kind of the natural way that the body relieves its pressure as well. And the other thing I just want to comment on, and I know Emily has some comments too in a second, is just this idea that it's okay for our conventional MIGs to not last forever. And then part of this IG mindset, and this is what I love about this case in general, is that it's okay for us to do something that lasts 1, 2, 3, 4 years, whatever, and then all of a sudden you have to do something else. We still got them control for that 3, 4 years, and we were off of drops for a period of time, and we avoided a trabid tube. And so it's okay for anybody out there who's like, oh, well, why even do a conventional MIGS if it's not going to last forever? And that mentality, I think we're changing now, because luckily we have so many options after our initial procedures don't do as well as we want long term. So great points there, George. But Emily, you had some comments just now. You were going to say.
Yeah, I just wanted to make some comments on the uveoscleral outflow pathway, because I think that there are so many younger surgeons out there, and even medical students and residents, that may have some different ideas about this pathway. Traditionally, we've been taught that it drains like 10 to 15% of aqueous humor, but there's been some newer papers that have shown that it's potentially much more, up to 50 to 60%, depending on age and other factors. And so this is a huge area for glaucoma surgery. And, like George said, we're still learning a lot about suprachoroidal fibrosis and cleft closure. And I think that there's a lot to learn here, but I think there's also a lot of potential that we're actively figuring out right now.
Yeah, no, that's a really good point, and I'm gonna ask George a couple of things here second. But yes, so what I did in this case, just so I'm gonna spill the beans already, I did do an Alaflow in this patient. So to me, this was a perfect Alaflow case. I love Zens too. I'm a huge Zen fan. I do a bunch every week. But I think this is a case where why not? If you can get a patient, and the negative pressure gradient. Remember, everybody, one thing we don't know about the conventional pathway is where the resistance to outflow is, and how much of a resistance is the TM, the canal, the episcleral venous system, et cetera. And because we don't know all that, we're kind of sometimes hedging our bets, guessing a little bit there. But with the negative pressure gradient of the supraciliary space, we have that power of that space, and we have a pretty good chance of not just getting the pressures down, but getting them off of medications. So with that said, hey, George, I know you've done a lot of Alaflow too, and more than me probably. So I was going to ask you, talk to everybody out there and describe what is Alaflow, just so everyone's on the same page, and we'll talk about some pearls. Go ahead first.
Yeah, sure. So, some of it's nomenclature. So it's kind of marketed as the uveoscleral pathway, but it's really a suprachoroidal device like CyPass is. Now, you may say, hey, what's the difference? I mean, there is a difference. It's kind of the same, but it's kind of different. And that's like a whole like hour long discussion, but whatever you want to call it. I think I think it's kind of a marketing thing basically, but whatever you want to call it, it is a highly effective pathway that we can utilize with, I think, pretty low complication rate and high success rate. So basically, we are creating a controlled cyclodialysis cleft. Okay, and when you say that, of course, oh my God, traumatic cyclodialysis cleft, hypotony, I have to fix it. That's not what this is. Okay, it's a controlled surgical opening, and then we know that clefts can close. Traumatic clefts can close. We purposely closed traumatic clefts. We got a huge, IOP spike. So we want to keep this cleft open and functioning. And to do that, we put in these scleral spacers. This is biocompatible processed tissue. Body doesn't reject it. It's the same stuff that your eye is made of, and it's very, very compatible with the eye. And it's also a very easy surgery. I mean, when you have a glaucoma surgery that you can do in the time of a cataract surgery with the same level of safety, same recovery time that actually works really great, I mean, that's a winner. So I am a huge fan of Alpha in the right patient. Okay. And I would only say to our audience that if you've got a mild to moderate patient, failed angle MIGS, think about Alaflow. I've also used it to be quite honest in patients that have kind of run out of other options. They've failed a trab. We've needled it a couple times. We put in the tube did something, had to get revised or removed. I mean, we all have these, really kind of difficult, challenging cases. And we're like, well, do I want to start, frying the ciliary body or put a second or tube in? No, I would rather do an Alaflow that I can do in 15 minutes. And it actually has, rescued, a lot of patients that, completely avoided doing a more invasive surgery and getting them, under control or off some drops. So I would encourage anybody who's comfortable in the angle, has done a lot of angle MIGs, to try Alpha. Now, you have to get over this mental block, right? Because when you're putting in your stent or you're doing your Cahook, your glide or any other MIGs, you're like, don't make a cleft. That's like the last thing you want to do. Because if you make a cleft, and we've all done it, accidentally made a cleft. We've all dropped some eye stents or whatever back there. You're actually trying to make a cleft, and it is pretty decent size. So you got to get over this mental hang up of not wanting to make a cleft. You want to make a cleft, you want to make it decent sized. I use 2 spacers. Some people use 1. Other people have talked about using more. I've gone with 2 spacers, sort of at least 2 spacer widths apart, and I've been pretty happy with my results. Again, doesn't work in everybody. You got to watch out for the failures. You got to keep them on the meds for a while, but I think it's a great, another toolkit on our MIGS armamentarium, to deal with cases like this.
No, that's a great point, and I think the key is understanding kind of how to create that cleft initially. When we first started doing this, we started doing psi passes, and we did things like mini jack and other devices. I've been involved with the UV scleral pathway for a while now, and I think what's nice is being able to create a cleft with your cycloelasto spatula or any kind of, let's say, even a viscoelastic cannula, and then really viscodilating that space. Once you get that space created, it is so simple just to put those spaces in there, and that's what makes it so controlled, I think, versus before when we were using loaders to create that cleft. It was a little bit more ambiguous. We were uncertain, and we didn't really see as much. So I think it's much more controlled now. And I would say, I love Emily's thoughts on this too. From a mechanism of action, what I have found now is creating that posterior dissection, because you've probably seen even clefts, even traumatic clefts. You have a wide cleft at the level of scleral spur, but then the pressures aren't that low. You have a small mini cleft that you're like, it's only like maybe half a clock hour, but there's pressures are super low. Why is that? It's because it's distally, posteriorly is where it closes up a lot of times. And so I think getting viscoelastic way back there when you're making your cleft, spreading out that posterior distal area. So when you put those spacers in there, like a bridge almost, then it really not only anteriorly is open, but posteriorly you have that space open. I'd love to hear your thoughts on that, guys. But that's kind of what I've been focusing on now too, is really getting that posterior flow and getting that viscoelastic way back there.
Because it's football season coming up, I think of it as goalposts. Okay, you want to
There you
get
go.
into the
I like it.
goalposts. But yeah, I
Get into
agree,
the
totally
goalpost.
agree, Paul. Because remember with side pass, we talked about, injecting, viscoelastic to create that, the ciliary suprachoroidal lake, right? Remember we kind of talked about that. I think the presence of a suprachoroidal lake is key to getting these things to work. And I haven't done the UBMs to kind of look at, the ones that worked and the ones that didn't, and the ones that failed, to see what's happening back there. But I think that would be really interesting. And I completely agree that getting back there, doing that posterior dissection to keep that suprachoroidal lake open is the key to long-term success. I don't know, what are your thoughts on that, Emily?
No, I totally agree. I was just going to also comment on sort of the cleft creation because, George, you were talking about how, oh, we've all done it, we've all created a cleft, and we're doing that by accident, right? Or it's a traumatic cleft, so it's already there. So, this procedure's been around since 1905. So cleft creation is nothing new. But I think for younger surgeon, it's something that we really don't think about. So, Paul, you were talking about using the viscoelastic cannula to create the cleft. And I actually disagree. I think that using like a Coke spatula or cyclodialysis spatula or even the inserter itself to create the cleft is actually much better because you really want to see the underside of the scleral wall, right? You want to see that white scleral wall. You don't want to see this sort of black hole because the danger there is that you're just sort of splitting the iris. And so I think that and I think, George, you have some great photos that you've posted previously. I think thinking about the cleft creation and exactly how you're going to do it. And certainly you want to tamponade that with viscoelastic and create that posterior dissection. That is really important. But we need to train our younger surgeons to really think about how to create that cleft.
We got 3 glaucoma specialists here. We're gonna have 4 or 5 different opinions about how to do this, which is what I love about glaucoma. So the original cyclodialysis spatula was made for that ancient history surgery. If you look up the papers, they didn't do it ab interno. This was like you open the conge, make a posterior scleral incision, and put that spatula from behind and go forward. That's what it was designed to do. This is totally different. So don't use the cyclodialysis spatula ab internally because that's not what it was created for. I love, the instrument that the company's developed was called the Spanula. So it is a spatula cannula that you put on your Provisc. It's got kind of a blunt but kind of tapered edge so it can peel that ciliary body off. And because you got your finger right on that Provisc syringe, you just shoot some Provisc in there as soon as it starts to bleed. And you can get almost a bloodless dissection, which is really, really nice. And you can also, it's got a little edge so you can actually use it to extend the cleft a little bit to the left, a little bit to the right to get the right size. So that's my favorite instrument this month for doing it. I've used George Reese's instruments as well. I've used the Provisc cannula. I've used the injector. There's so many different ways. And that's what I love about this. It's a procedure and evolution, and all of us have some say and input in how we develop this surgery. And I love that because we have such a great community of doctors with so many creative ideas. You, Emily, you, Paul, others, we're all together in this and communicating and sharing our thoughts.
No, I love it. That's such a good point. And to your point, Emily and George. So I think you're absolutely right. I mean, I'm not a huge fan of the viscoelastic cannula, but you can do it that way. But here's the key, though. To your point, I think the spanulas are important. Cyclodialysis spatula, Coke spatula. I think a spatula is better, especially it's wider, a little more blunt. It can kind of dissect better. Absolutely right. But the key I've found is when you engage, don't go directly at the level of iris tissue. I start at the level of sclerospur, the white band you see below the TM, and I go and I push towards that sclerospur and then dip down a little bit. As I'm pushing against the sclerospur and then start to dip down a little bit there, it'll naturally find that cleft space. So that's what I find a lot of doctors doing is if they go too low to begin with, they just start to cause bleeding. They start to pull iris away and they start to create that separation. So whatever you're using, I think starting at that level of sclerospur, in my opinion, and then kind of going downward, you kind of find that space. It kind of pops in. But there's a lot of nuances to it. And I think that's where the training comes in, is just getting comfortable with that. But once you get that down, to George's point earlier, I think it is easy to slip those spaces in nicely as well. And in this patient did great, by the way. I mean, this patient's still off about a month or so now, but patients more than that, about 6 weeks. Patients off of med still, pressure's down to the 13, 14 range so far. So doing well. There is a chance, as George mentioned, that sometimes these patients' pressures can go up at like 3 or 4 weeks. You can get that pressure spike a little bit there. So that's something you got to watch for. So sometimes you want to keep them on, some aqueous suppressants. And I'm not sure if you agree with that, George, but you got to be careful of that as well. But in general, the patient is doing really well. So it's a great opportunity. You could always go back and do, something in the subconscious space, a Zen later on, or a Travin tube, even ECP. So you still have a lot of options if this doesn't do enough. It's all about educating the patient on the front end as well. Emily, any thoughts on that before we move on?
I guess I just want to ask you, Paul, kind of what you do intraoperatively for pain control for these patients. Because initially, I was doing like a subtenons, even sometimes a retro bulbar if the patient was really concerned. How do you typically handle that? Because sometimes they can feel the stents going in.
They can. I still will do just a little snip down, a little peribulbar. Just do a little snip down at the level, like 4 millimeters behind the limbus, a small snip in the conge, go underneath the T9, just squirt some, lidocaine marking, kind of thing, and that usually does a good job. So I don't like retrobulbars honestly, but think that is such an easy that's a subtenon slash peribulbar is such a nice and easy way to do that. And I use these little stay sutures that kind of keep the eye still, so I don't have my eyes moving. So for me, these patients are really comfortable, and it's a pretty, as George said, it's pretty effective and pretty efficient. I mean, I hate to say fast because nothing is ever fast with you never know, but it is an efficient procedure that we do now, and it doesn't take a lot of real estate also. So you can go into multiple places where I've had a previous hydrus in one case where I was able to fit it next to that. So it's actually something that can be used in any patient who's had a previous conventional MIGS. No, but that's a good question, Emily. I appreciate that. Just for the sake of time, though, I want to get to just the audience questions and audience rather surveys. And so we're going to talk about Instagram first. When we said, what would you do next after we had the history? And we had majority of people in the Instagram world say between repeating SLT or do like a micropulse or some type of laser or do a surgical intervention. So but there was about 30% here who said, let's do drug delivery, like an iDose. So I think you're absolutely right. This could be a Durysta or an iDose, just to get them off the PGA even, and that might give it enough benefit for that patient too as well. So absolutely, we definitely want to consider all the options, as nothing is right or wrong. And then if we do a surgery, which most people said do some type of surgical intervention, what would you do next? Majority of doctors said do a subconj, like an aqualumin, which is something I'm doing now recently as well, which is a needle that has a little cutout. I'm not sure if anyone's heard of that. The aqualumin is a new device where you go under the subconj, like an Abbott external Zen transconj, but without a needle, without a stent. You have a needle that has a cutout. When you go into the antechamber and come back out, it creates a little tunnel, and that tunnel is what allows to bypass the conventional pathway and go right into the subconj space. So like a Zen, but there's about 57% of people who thought let's say do subconj, and then really about 11% said Alaflow, 25% did do another goniotomy. So I think there's definitely a variation. Even 8% said cyclodestruction. So what does it tell you? Do what is comfortable for you. Realize that nothing's perfect, and you may have to do something else beyond that. So absolutely, to Emily's point, a Zen subcon surgery, it would be another option for sure as well. Going over quickly to LinkedIn. LinkedIn, same idea. People said, let's do surgical intervention. About 50% do a surgical intervention. About 15% said, let's do some type of SLT micropulse. About 30% do drug delivery. So it's good to see that drug delivery is on people's minds. And I think it's a great opportunity. Durysta in the office or an iDose going into the procedure and combining it maybe with, like, say, like a goniotomy, to Emily's point earlier, absolutely could be an option. Maybe get them off of one or two, even more meds. You never know as well. And then if you do surgery, what would you do? Again, most people said 60% said subconj. About 25% said Alaflow. So we're seeing more people, I think, considering Alaflow in the LinkedIn world than the Instagram world. And then lastly, Twitter. It was interesting. It was a little bit more aggressive. Twitter more aggressive. Let's say 83% said let's do a surgical intervention. About 17% said let's do a drug delivery. So a little bit more push to the surgical intervention. And when it said what type of intervention, still subconj is where people were at. Subconj Zen or something else as well. About 14% said Alaflow or subsuperciliary spacer. There were some more in the cyclodestruction in the Twitter people. So like an ECP might be a good option. And there's no wrong in that. I think all those options, goniotomies, superciliary spacers, cyclodestruction, or even subconj, all are options depending on your comfort level and what you can do next after that as well. But in this case, we went ahead, like we talked about why, we did the Alaflow as well. And so far the patient's doing well, but if it does fail eventually, guess what? We have those other options we can still utilize if need be as well. That was a pretty cool case. I mean, I think that was a good overview of kind of the options, that waiting to do nothing is probably the only wrong option, letting this patient suffer. And that's kind of the IG mindset, right? The definition of what is controlled glaucoma is no longer fields are stable, nerves are stable, pressures are where I want them to be. It's also how is a patient's quality of life and are they really able to stay on that current regimen long term. If someone's saying, I can't do this, like cost, side effects, whatever, dry eye, then you know what? We got to do something to get them off. And so that's the basic gist of this case. But yeah, I think an Alaflow would be a good case, but other options are still on the table. And if you don't do one of the other options, you have another option later on if you need to.
Yeah, so I completely agree with Emily's points. I think Alaflow would be an excellent choice of a procedure in this woman. It is a MIGS surgery. We haven't had a suprachoroidal MIGS since CyPass was taken off the market. It is a relatively non-invasive surgery that is very effective. All my patients have said that the recovery is very quick, and we've actually been able to get people down in at least the mid-teens or below without medications. And so, given this woman's problems using eye drops, given the fact that she's already failed some angle MIGs, I think Alaflow would be an excellent choice. Uh, my approach is I usually create at least, a 2 clock hour cyclodialysis. I tend to make them a little bit bigger, and I always use 2 spacers. And I think it's really important. I think Emily alluded to this, that creating a good posterior viscodissection is really key, because you want to establish a suprachoroidal lake in order for the aqueous to flow into that lake and then diffuse into the choroidal vessels. So I think posterior dissection is really key. I think making the cleft a little bit wider than we initially did with this surgery is also important. And with those things, in mind, we've been really pretty happy with our results with Alaflow in patients just like this case.
Talk to me at the end here before we end. How do you talk to your patients? So let's say you have a patient going for standalone MIGs. And there is that fear for all of us. What if it doesn't work? What if I don't get to the desired result of reduce IOP or reduce drop burden? What do you tell your patients, and how do you educate them on the front end?
First, I would say I always discuss the pros and the cons of different procedures with each patient. But one thing that I think is really important, because we have so many options, is always give a strong recommendation. Always say we have option A and option B, and my opinion is we should do option A. Because as we get older, and we sort of enter the healthcare system and we've had surgeries done on ourselves, we sort of recognize we're not the expert in knees, and so our patients are not experts in eyes, so we have to give them a strong recommendation. But I also am very honest with them. This is a chronic disease. It's likely that you will require multiple procedures over your lifetime. You have to say that. You can't pretend that one procedure is going to cure their disease, because it is not. And I always really just try to take a very step-by-step approach. What is the safest thing for the patient? What fits with their quality of life and their lifestyle? And then escalate the care from there.
Yeah, I think what you said is so key, is educating them on the front end to expect that they're going to need more than one type of technology / procedure along the course of their lifespan. And if you say that in the front end, where they expect that, then you're not beholden to any one procedure saying, oh no, it doesn't work, it didn't do enough, oh no, I'm in trouble. And I say, look, everyone's anatomy is different. Everyone's glaucoma is different. I put it back on the patient that, the surgery may go great, but your anatomy may be different. And we don't know for every patient how they're going to react to any given procedure or technology as well. But I do sell in a positive way, say, but we're lucky now. So in glaucoma, we have options. We have abilities to do different things depending on what the eye shows us. So don't worry, we'll try this first. If it doesn't do enough, and I say never say it doesn't work. I say if it doesn't do what we want it to do, or doesn't get us low enough for you, we have other things we can add to that. So there's always that kind of, not like SOT. It's not like, oh, if SOT doesn't work, what do? I say if SOT doesn't get us low enough, that's okay. We have other things like drug delivery and MIGs and topical drops if we have to. So drops are like there as a bridge. So, but I want to thank BMC. I want to thank, of course, all you out there for giving us your time to listen to us babble. And hopefully this was helpful to you as well. And if you do want to know more about the Alaflow, a company called IonTrek is the one who's the company that actually sells that product as well. You can reach out to them, and so many other products that are out there. So just keep an open mind, and hopefully this helped you. And we'll hopefully see you guys in the next episode of Survey Says.
Thank you for tuning into this episode of GT the Podcast. If you have any feedback or topic suggestions, find us on Instagram, LinkedIn, Facebook, or Twitter. And stay tuned for more hot topics in glaucoma care on GT the Podcast.